Good morning. If Leslie Thompson would be seated, we can get underway. Thank you, Leslie. I think we got such a good conversation going last evening that it's going to be trouble for who's ever chairing today. But let me welcome those of you who are with us for that, I thought, outstanding discussion last evening back today. And those who are joining us for the first time, welcome. I think you will find a series of both conversations and presentations that will be of great interest to you. I want to again thank the team at OSSU and Vasanti in particular for getting us to this point. We will be formally announcing the Impact Awards a little later in the day, although it's an open secret since descriptions of them are in your package, and there are people with big smiles on their face around the room, so it's relatively easy to identify the successful people in this endeavor. This is a very important piece of business. I know that the tendency in healthcare is to be focused on, as Jeff Simpson was yesterday, how we pay physicians, and that is, of course, an important issue. And I think Jeff did a favor to all of us in getting that discussion kind of reignited and providing a little cover for Dr. Bell and other deputies who are going to be, I think, sleeves rolled up on that issue. But the issue of patients and the issue of bringing the research agenda, if I can call it that, and the needs and hopes of patients, we did talk about hope last night, and I think it's a good word, together. And to do that without sacrificing on one side the authenticity of what patients feel and experience, and on the other side, without giving up the scientific enterprise, is an interesting marriage to try and broker. And yet this process has enormous potential, because if we can do that, if we can focus the enormous talent that's been assembled in this province over 2 decades in a whole series of institutions and organizations that each on their own is incredibly valuable, but networked together and focused on the patient agenda, I think have more potential to transform the health system than anything else that I'm aware of. Believe me, I have the scar tissue from many other efforts to do this with a big club, to do this with, new money. But at the heart of this is we are trying to change something that has been in place for a very, very long time, and for, I think, good reasons. I mean, we, for more than decades, for centuries, had a system that was, I think, appropriately dominated by providers because they had the knowledge, and many of the things that we did in medicine and in healthcare were things that didn't require a participating patient in a lot of ways. And that's transformed. We've achieved the big victory we wanted. We are living longer, but we're not living longer in perfect health. We're living with one or more chronic diseases, and now we need a different health system. We need one where patients' voices do come to bear, not only on their own journey, but on the overall organization and structure and management and behavior of the system, including providers. So I want to stop there. I do want to say a couple of things about Bob Bell, because it's been my privilege to work with him. We first worked intensively together on the Cancer Quality Council. And for me, after CHI, and which was a wonderful experience, in the National Health Council, which, to be fair, was something that had great hopes, but ended up not surviving the ministerial pushback. The Cancer Quality Council was the first time I'd really been in a place where we engaged clinical leadership with the data and with an accountability and public reporting that Staney Brown played a big role in helping us develop. But I came to realize one other thing. It would not have worked without Bob's very determined and very thoughtful contribution. And everything in health is a relay race. And When I stepped down, Bob picked up the baton and moved the council forward in a really powerful way. And this morning I was thinking about it, and it's not the only baton. Now, I handed the deputy minister baton off a couple of decades ago, and he's picked it up recently, and I'm delighted. I've had occasion, most recently in Washington last week, to hear him present on the agenda that he and the minister are pursuing. I think it's entirely the right agenda, and they are pursuing it with considerable vigor. And I don't think there's a better person in this province to be carrying the baton. So, Bob.
Thank you, Michael. Michael, thank you for those very kind words. And I'd like to pay just a moment's tribute to Michael and also to the OSSU team, to Vasanthi and her team. But Michael, especially to you, because your career has been so committed. Your volunteer career, most of us in this room are paid to be here, you're not. And the sense that you bring to the table of both aspiration for what we want to achieve for patients, but most importantly, the reflection of the patient voice and what we're trying to accomplish. Michael, thanks to you for your volunteer leadership, which has made the Ontario health system richer over the years and continues through its support of the OSSU program. I want to tell you all in the room, and I'm speaking on behalf of Minister Hoskins, that you work for us, all right? You work for us, and I'm saying that in the most positive way, in that we represent, through the democratic process, the needs of patients in this province. It's our job to reflect those needs, to reflect it in strategy and policy, determinations of how funding gets allocated. We also work on behalf of Ontario taxpayers. And in signing up for the support unit and the strategy for patient-oriented research, you work for us, because we need your talent, but you also need to know what we need. And we need new information that can be implemented at the point of care based on best practices for the big, hairy, audacious problems that we're facing. And I'm just delighted at some of the, I understand, open secrets of where our first impact awards are going. When I look at where we have challenges in our health system, we all recognize the apocryphal story of the 5% of patients who, those poorly served patients who cost a lot of money. Well, we initiated something a few years ago called HealthLinks. So it's been enormously successful, increasingly successful. But as often happens in healthcare, we did that solution without truly understanding the problem set that we were addressing. We knew there were 5% of patients, but we didn't really honestly know who all those patients were. So one person you should definitely get to know is Walter Wochus, because Walter is doing terrific work in telling us the segmentation of this group of patients. And one group that surprised me a bit was patients who are admitted to hospital for unplanned surgical procedures who cost a ton of money with that surgical admission. Now, obviously, those folks are not they may be helped by HealthLinks in the long run, but for that episode of unplanned surgical encounter, unlikely to be helped. When you look further down into that data, guess what a lot of those folks have? Hip fractures, right? Hip fractures that have prolonged length of stay. And our Ontario approach to hip fracture, I can tell you because I'm an orthopedic surgeon, where we tune up patients for a couple of days, getting them ready for the OR, is disastrous. Those people should be in the OR immediately so they can start back in the mobilization. And guess what? The first thing I see here, in terms of you're addressing that issue. Isn't that terrific? The second issue we've got, in terms of improving public health in this province and accomplishing the toughest of the triple aims, is we need to deal with Aboriginal health. We can make enormous progress in the public health of Ontario by dealing with our citizens who have the poorest outcomes in public health terms. And what's the second thing? Reducing the burden of diabetes in First Nations. Isn't that great? The third thing that we've got enormous challenges with is mental health. And the SPOR National Network, I was delighted that the first SPOR National Network with the support of the Beck Foundation related to transitional aged youth, where we recognize that mental health issues can be identified and a future of an unhappy life for patient and family possibly reversed with different approaches to recognition of mental health symptoms early on. Clearly, mental health is something that we do not do well in Ontario. I'm delighted to see that 2 of the projects that are being funded relate to mental health outcomes. So, I can go on and on. The fact that we're looking at management of congestive heart failure, keeping people out of hospital. Another thing that's a big problem for us. So when I think of the problem sets that we're addressing in bringing best practice to Ontario, it's wonderful that the support unit approach is addressing some of these big, hairy problems that we need new solutions for. My challenge to you, and especially those investigators in the room who've been successful in the first round, is please start planning your implementation process now. That's another thing that we're trying to do in the ministry, is we're trying to serve not as a block to innovation, be it industrial innovation brought to us by Ontario companies, brought to us by international companies. We want to be open for business, that if something is effective and cost-effective, especially if it's demonstrated its ability to be effective and cost-effective in the Ontario environment, we want to be a pull. We want to be looking for solutions. In fact, we're just about to hire a Chief Health Innovation Strategist whose job it will be to sit at the ministry table, senior table, and look for opportunities to pull innovation into our system for economic benefit, but also specifically for patient care benefit. And, that implementation step needs to be a part, and I know it is a part of each one of these studies, because if it is effective, and we're not going to neglect the science and demonstration that something is effective and cost-effective, that it does improve outcomes for Ontario patients. We're not going to be silly and say innovation. If it's new, we're going to implement it. But if it does work in these well-structured approaches to clinical evidence obtaining, that's not good enough. We need to know from the starting point how you see the projects being implemented. Where are the communities of practice in orthopedic surgery that, if early access to hip fixation is effective, as I guess it will be, but it needs to be seen. But if that is the case, where are the changes to the OR scheduling of urgent cases? How does hip surgery become an A case rather than a C case in all 110 hospitals across Ontario that do hip fracture surgery? How do we think of alignment of the OHIP fee schedule so that if you're not getting the hip fracture patient to the operating room, how do we think of the realignment of pre-surgical medical consultation fees so that we're thinking about consults done at the OR door? And you can imagine the changes that are necessary to implement that kind of change in practice. And that crucially needs to be part of the OSSU message, that we're not just here about developing evidence, we're not just here about addressing issues that mean something to Ontario patients. We're also thinking about how we get that evidence into practice in a direct line with no light showing between the study that demonstrates effectiveness and the implementation plan that brings it into practice for all Ontarians. And I think that's a crucial piece of the SPOR message. It's give tremendous credit to Alain Baudet. Michael talked about scars. Believe me, Alain Baudet wears the scars of changing the direction of CIHR from an organization that is internationally renowned and will continue to be internationally renowned at producing evidence, to an organization that also says patients want change. We need to listen to patients about what change is important, and we crucially need to make sure that we're asking questions related to issues that patients question, and not just good enough to answer those questions with reliable evidence. That's essential, no question, but we also need to speak to the science of how we implement those changes for systems. So I'm extremely excited, obviously, about the strategy for patient-oriented research at the national level. I was telling Michael and Leslie, we spent an hour and a half at the deputies table the last couple of days talking about SPOR, talking about how deputies need to be linked to that strategy table as representatives of the funding that patients provide, that taxpayers provide for the healthcare system in Canada. We need to be there. We need to be, along with patients who are represented at that table, we need to be represented as patients and citizens representatives saying, here are the big hairy problems, here's what we need answers to, and oh, by the way, we also need your advice, and I'm delighted to see a provincial implementation science laboratory. How exciting is that? Along with the funding that goes to Ottawa around implementation elements in the support unit core funding. That focus on implementation is something that patients want, because if you've spoken to citizens in Canada about the CIHR, if they're aware of it, they say, yeah, it's great, it's internationally significant, it produces evidence, we're proud that it's there. I don't think it really has any impact on what happens in my family doctor's office. So I think that's the challenge, but the huge opportunity. You know, we've got folks in the ministry, the Chief Innovation Strategist, Michael Hilmer's branch in the ministry, that are thinking through how we pull and thinking through how we pose. Posing questions to you, looking at your research outcomes, thinking about how we pull them into the system, working with groups like CAHO, whose Arctic projects have demonstrated very well that a focus on implementation science, a focus on change management, truly makes a difference in outcomes for patients. We're at a really, I think, important and unique time. We've got a $50 billion industry that we know is going to grow more slowly than it has in the past. We know that that industry needs to think about what patients want in terms of customer service, in terms of the services that they want. I think we're doing a better job of listening to that. That needs to improve even further. But we also need new ideas that are transformational. And I'll go back to the example that I know best, and that is the example that's being funded here about a hip fracture patient. So the story that currently exists, and in my career has existed, where Mrs. Smith at the age of 82, I used to work at St. Mike's, and we used to see 2 or 3 patients a week who got caught in the revolving door of the old Simpsons building on Yonge Street who had come to St. Mike's with a fractured hip. They'd inevitably be on 3 drugs, and we'd say, well, they need to have a medical consult. Poor Mrs. Smith would lie in agony for 3 days, waiting for the medical consult, waiting for the operating room to be booked. By the time she actually got her hip fracture fixed with a general anesthetic that increased her level of confusion, she couldn't participate in any degree of rehab for the next 10 days. And by that time, Mrs. Smith was condemned to a long-term care center. She just couldn't get it back. As opposed to, I think, what Dr. Devereaux and colleagues are thinking about as we focus on the needs of aging patients, as we recognize that unfortunately folks have osteopenia. That needs to be changed in the long run, but we've got a few more years of dealing with osteopenia. Mrs. Smith needs to be dealt with. I think we need to test the hypothesis that treating her as a surgical emergency will make a difference to her condemnation to a long-term care center. I think it's true. And if it is true, boy, we need to fix that fast. So congratulations to all the winners in the room. Thank you for the work that you're doing. Congratulations, Vasanthi, for a wonderful start to our support unit programs. I haven't had a chance to talk about the wonderful things that ISIS is going to produce in terms of real-world verification of clinical trial information, in terms of anticipation of how we can conduct cluster randomized trials in different ways in this province, more cost effectively with the resources that ISIS has in terms of the availability of ISIS information for industry. Just so many different opportunities that exist within our support unit approach here. Congratulations, Vasanthi, for getting us off to a great start. Michael, thank you so much for your continued leadership of what patients want and need in this province, and it's going to be fun. I'm delighted you're all working for me. Thank you very much.